Thank you. Thank you. Can everyone hear me? Yes. Clearly? Okay, great. So it's really my pleasure to come talk to you today. I think one of the goals for this talk is to really just educate you a little bit more about back pain, the different types of things that can cause back pain, and some of the treatments that we can offer that aren't invasive. Things like injections, same-day procedures, things that won't keep you down for a period of time. We like to keep you as active as we can, and certainly all the things we're going to talk about today will help you do that. So just a little bit about myself. I'm a Pennsylvania native. I grew up in the Scranton area, so I don't know if there's anyone from Scranton here? Close enough, right? And went to college there and trained in the Philadelphia area, and then decided to work in this area. I was in private practice before I joined Coordinated Health for about a year and a half to 2 years. So I've seen both sides of things from a standpoint of being employed by a company versus being in my own practice. And I have to tell you that the seamlessness and the ease of practicing in a health system like this and having everything at your disposal, between getting MRI sometimes the same day, next day, seeing you back, and there's not that delay. So things happen quite quickly and efficiently for us, and more so for the patient. Everything's centered at this health system for the patient. So everyone ready to start? Mm-hmm. All right. And if you have any questions, feel free to stop me in the middle, or we have that Q&A session at the end as well. So this is to say that I'm on my own here. Coordinated Health does not endorse anything we're talking about today. So just with low back pain, I think it's really important to understand that low back pain is so common. It's an epidemic. And this is a busy slide, but just take away that it's really second only to upper respiratory infections as the most frequent cause of missing work. I mean, that's a staggering number. The economic impact of that, from missing work, doctor's visits, procedures, therapy, it's over billions and billions and billions of dollars per year. And when I came across the stat, I was kind of flabbergasted that after 6 months of not working, only about half of people will return to work due to low back injury. After about a year, 25%. 2 years, there's no chance. You're not going back to work. So that's a great stat, and something to look at. Is my goal is to keep you working, keep you functional, and keep you doing the things that you love to do. So the spine is a big puzzle. There's lots of different things that can cause pain in the spine. So just a little bit about the anatomy here. These are the bones that make up our spine. They're called the vertebral bodies. In between these are discs. The discs act as cushions, and they can cause some issues. They can get degenerative or arthritic. They break down, they lose the amount of water they have, and they get narrow. They can cause some bulging, and that might not be a problem. Bulging discs can be normal. They can herniate, and that's just a little bit of a different terminology, and they can end up pushing on some nerves and causing some pretty significant pain. In addition to the discs, there's joints here. They're called the facet joints. Those can cause pain themselves. Even the vertebral bodies can cause pain. You can have fractures of these, and as we get older, that's a big problem. I saw a lady this morning, she was about 75, and she fell last week, and she had a fracture. And when they took the initial x-rays, they didn't really see it, and we took them again, and it increased. And that's what's causing her pain. So there's many different things. In addition to all the anatomy in the spine, sometimes back pain might actually be something like hip arthritis. So you have to really examine the patient, put your hands on the patient, and really determine exactly what the source of the pain is. You can often get back pain from locations that aren't in the back. So from a urologic standpoint or a GI standpoint, your stomach, all those things can cause back pain. So it's really important, if you do have chronic back pain, to get evaluated, because it can be a number of different things, and our job is to help find out exactly what that is. So there are some red flags to back pain. When I hear a patient say this, it's almost like, nope, right to the MRI machine, we're going to get some imaging today. Significant weight loss, unintentional, fevers or chills. That can indicate something like an infection in the disc or something like an abscess. If you have any problems as far as holding your urine or holding your stool, certainly, those are their own systems in themselves, but certainly that can be referred from the back, and that's more of a neurologic emergency. Any problems with sexual dysfunction or problems walking, that's more of, again, an issue that needs to get evaluated quickly. And here's a big one, is weakness. So a lot of patients will come to me and saying, oh, well, I've been tripping, or I'm trying to walk and I'm dragging my foot, or I'm slapping my foot, And that's certainly a sign that you have some nerve compression going on, and we really need to take care of it. So the natural course of low back pain, and this is a good thing, is very favorable. Usually it's going to go away on its own, even if we do nothing. So about 50% of low back pain will resolve in a 1 to 2 week period. Even a higher amount will resolve in 6 to 12 weeks, over 90%. And that might be with a little bit of conservative treatment, maybe some therapy and some medications, and you'll do just fine. But the problem becomes is when it recurs, and it will recur in the vast majority of people. So about 85% of people with low back pain will have a recurrence within a 1 to 2 year period. So what do we do to treat that? We can do nothing. We can watch and wait. We can try some medications, and we'll discuss a little bit of those, as well as proceeding to things like imaging or MRI imaging or CAT scan imaging if we're having persistent pain. We can get you into some physical therapy or chiropractic treatment, and we're also going to review a couple injection techniques. I'm not going to discuss surgery too much today, but we do have wonderful orthopedic spine surgeons that I work with closely at Coordinated Health, and I'll often see you first, or they'll see you first, and we'll refer kind of back and forth and come up with the best treatment plan for you. So from a medication standpoint, the mainstays are nonsteroidal anti-inflammatory drugs, things like ibuprofen or naproxen. We know them as Advil, Aleve. They become in prescription forms. There's also things like meloxicam or Mobic or things like Celebrex. So there's many different types of medications. They're called the non-steroidal anti-inflammatories, and they have their risks and big risks with regards to the kidney and the stomach. There's steroidal anti-inflammatories, things like corticosteroids, which we use in injections, and we can talk about that a little bit, but you can also take those by mouth. There's things to stabilize nerve membranes, different types of medications for that, as well as muscle relaxants. And then when things are pretty severe, if there's something like an acute disc herniation or a different type of pain syndrome, we do often use these medications. They are controlled medications, and we know the big problem with opiates in the country, so these are used very judiciously, as well as topical type medications if you can't tolerate something by mouth. So say we tried some medications and we're still having some discomfort, we may get you into some physical therapy. And the goal of physical therapy is really postural training. It's to improve your flexibility, strengthen up your core. We will use things like modalities, heat, ice, ultrasound, massage, manual type therapy, as well as things like traction. And specifically when there's neural compression, traction seems to offer patients a lot of relief, as well as they're going to develop a home exercise program for you. And that's very important because we can get you better, but it's sort of up to you sometimes to maintain that and continue with the home exercise program and keep your core strong. So therapy is great as far as improving your pain as well as educating you on how to keep it away. One of the biggest approaches we use with our certified spine therapists is the McKenzie approach. And this is a busy slide as well, but just with the McKenzie approach, it's been around for a long time. The goal of the McKenzie approach is to centralize your pain. And we're going to talk about different types of pain in a second, but leg pain and arm pain can be related to low back or neck pain. It's called radicular pain. So the goal of the McKenzie program is more for back and leg pain. It's an extension-based program. We're trying to get pain away from the legs and closer to the back. And generally that's much better tolerated by patients and people is back pain. So leg pain seems to be limiting because it's related to nerves and it's really debilitating. So in addition to physical therapy, we have a lot of chiropractors on our staff that do a great job at treating patients, and I'll often institute them first because sometimes when you have an acute injury or you're developed an acute episode of low back pain, this is a little bit better tolerated than trying to put you in therapy and mobilize you right away. So the goal of chiropractic therapy is really to restore your mobility by manipulation. So often patients will come to me with x-rays already done. That happens frequently. Sometimes we will get them. I typically don't use x-rays that often anymore, only in cases really where I'm concerned about a fracture. X-rays will show me bone very well. They don't really show us discs. You can see the bone is here. This is your vertebral body, and the discs separate them. They don't actually show up on the film, but they do show the spaces where the discs occupy. So you can see some narrowing here, a relatively well-preserved disc, but you can identify degenerative disc, you can identify some arthritis, but it doesn't show you the soft tissues. It doesn't show you the actual content of the disc or the nerves. In cases where we've tried physical therapy, we've tried medications, we've had persistent pain despite passage of time, we will often proceed with something like an MRI. Obviously, if there's a contraindication to an MRI, you have a pacemaker, you have metal in your body, we might get something like a CAT scan. MRIs are a little bit better than CAT scans in the sense that they really show us soft tissues better. The CAT scan does show us bone and gives us information, but MRIs are really the mainstay for us as far as planning your treatment, whether it be something like surgery or an injection. And when we talked about those red flags a little bit, if you came in with any of those, we'd probably get this right away rather than institute some conservative treatment. So this image here, we're actually cutting you this way. It's called the sagittal cut. So we're looking at you from the side. So here's your spinal canal. The nerve roots are coming down. All this white area is the spinal canal. And you can imagine, you can see a disc here, and it's nicely hydrated. It's a little brighter, and it's separating the bones. These discs look a little bit darker over here. Still, there's nice space in the spinal canal till we get to this area here, this L5-S1 area. You can see the disc, and there's material of the disc herniating backwards. It's pushing backwards and pressing on the nerves. So this patient would have pretty significant pain in the back of their legs. And we can look at a different view. This is called an axial cut, where we're cutting you from your feet to your head. So this is actually the left side of your screen, but it's the right side of your body. So you can imagine your feet would be this way and your head would be this way. And you can see here's a relatively normal disc in the axial view. Here are some nerves exiting the area called the foramen. Here are the joints back there. These are joints called the facet joints, and we'll talk about those a little bit as well. And here's the center part of your spinal canal. And you can see here how the disc is pushing posteriorly and is actually displacing the descending nerve. So that would definitely be causing some pain. And when we have images like this, we'll often say, how do we get you out of pain quickly? And one of the mainstays to relieve radicular pain, and that's leg pain from the back, or we often term it as sciatica. Sciatica is a broad term to just mean leg pain referred from the back. The sciatic nerve is never really involved. It's usually related to something like a disc herniation or spinal stenosis. And one person taught me something very simple. The spine's a bunch of holes. When things get tight, it causes pain. That's all you got to think about. So a disc may occupy that space, cause some pressing of the nerve and causing that leg pain, or it could be the bones are overgrowing, the ligaments are overgrowing, and that's causing a little bit of tightening there as well. So how do we choose a procedure? I received training, interventional spine training, so I do a lot of different procedures. How do you pick the right one? Well, you have to look at what the pathology is. If we think it's arthritis, we may go after a joint. We may put some medicine into a joint. We can block some nerves and end up burning those nerves. We'll talk about that a little bit. We can put some medicine inside a disc. We can try and stimulate a disc and make it painful. One of the mainstays of treatment, I'm sure a lot of people have heard about these, are epidural steroid injections. So what is an epidural steroid injection? It's done for radicular pain. We're actually putting corticosteroid or steroid-type medication in the epidural space. So things like disc herniation, spinal stenosis, or pain from the disc itself can all cause that radicular pain. It can be done in both the neck and low back, and they've been around for a long time. They've been around since 1901. That was the first described epidural steroid injection. It was the first described epidural injection. Steroid was first used in the 1950s. And the whole goal of them is to get rid of your pain, number one, but it also gives us information. It helps us identify whether or not that's the specific nerve that's involved. Is it the epidural space that's involved? So often I'll get patients from one of our orthopedic surgeons and they'll say, is this really the hip? Or is it maybe an L2-3 nerve that's getting compressed in the spine? And you can have both things. You can have hip arthritis and pain from the low back. So we'll often do one of these or a selective block and try and figure out exactly, is this the nerve that's involved or is it really your hip? And we use them for multiple reasons, but the mainstay is going to be treating your pain. So what is radicular pain? It's inflammation of the nerve root, and inflammation's the key. That's the whole reason why epidural steroids work. It's because there's inflammation of the nerve, and we know this by histologic studies. We have seen disc herniations, and when disc herniations happen, it causes this inflammatory cascade throughout our body. And these are just a lot of big words: phospholipase, leukotriene, all these are just inflammatory mediators. So things like disc herniations can certainly cause that inflammation. That's why those epidural steroid injections work. We're putting potent anti-inflammatory or corticosteroid type medications directly where the issue is. Additionally, steroids tend to inhibit neurotransmission in pain fibers. That's another way. Oftentimes patients will ask me, well, what's the issue? Why can't I take steroids by mouth? Why do I need to have this injection done? Well, the problem is we often can't reach a high enough concentration by mouth to give you good pain relief. So we'll often say, we can certainly try an oral steroid taper and see if that gives you relief, but generally the pain will return. One of the major things I stress with patients is injections need to be done the right way. I've seen a lot of procedures done that medicine's not getting to where the problem is. So patients will come in and they'll say, well, I don't want another injection. I've had these done 5 years ago and they didn't help me. Give us a chance. We do things the right way. Everything should be done under X-ray. That's fluoroscopy. So every needle should be advanced under live fluoroscopy image. Contrast needs to be utilized. So contrast is something that shows up dark under the X-ray. We'll talk about that. It allows you to see exactly where the medication's going and ensure that you're not in an area where you shouldn't be. And you have to use multiple views. So this is an example of a cervical transforaminal epidural steroid injection. So this is actually a patient's neck. So this would be a patient that had neck and arm pain. And you can see here, here's the disc. This is an area called the foramen. It's an opening where a nerve exits. So oftentimes you can have a disc herniation that's compressing the nerve in the area of the foramen. So this little needle is dark. It's that little line. So that needle is being advanced into the aspect of the foramen. And this is a second view. So this is almost like us looking at you from the side. And this one's us looking at you straight down. This dark medicine is contrast. So we'll inject that prior to injecting any medicine to ensure that we're around the nerve. We're not in something like a blood vessel, and it's flowing into the area of the epidural space. So this is probably the most, in addition to good needle control, this is the most important thing as far as interpreting contrast patterns. You need to ensure that it's going into the right area. And this is just another view demonstrating that, and it's very important to take multiple views. You can imagine if you're looking at just a straight view, how do you know where you are in three-dimensional space? You can't. You need multiple views. You could be way too deep, you could be way too shallow here, but this allows you to picture the needle in three-dimensional space. This is an example of an injection to the low back. So this needle is being guided. So this is the L5 vertebral body. This is the L4 vertebral body. And this needle is being guided into an area called just underneath the pedicle. And this area, this opening, is called a foramen. And often those can get tight and cause pain and nerve root irritation. So the needle's being placed just into the aspect of the foramen, and the contrast is being injected along the nerve and into the epidural space. So the epidural space is defined as here. So you want to see the contrast flow this way. So we touched a little bit about radicular pain. So that's that leg pain or arm pain related to things like disc herniations or stenosis, among other causes. What do you do when you just have back pain? Could you do an epidural? Sure, but they're not really indicated for that. Sometimes they will be helpful depending on the reason why you might have the pain. But generally for axial pain, we look at other generators or other anatomic causes of pain. So it's primarily pain in the low back and buttock area, not leg pain. So what really causes chronic axial pain? It could be the disc itself, and that's a talk that could take 2 weeks. The Z joint, also known as the facet joint. That's a very common cause as we get older of pain. They become arthritic, as well as the sacroiliac joint, which is just below the low back. As we get older, this becomes much more likely of a cause. This can still be a cause, but you generally see this throughout our lives, really. And this is kind of controversial in itself, but we do see it. Facet joints are very commonly a cause of just axial or back pain as we age. So one of the mainstays as far as procedures that we do that tends to really give you lasting relief is something called radiofrequency neurotomy. So what that is, if you can imagine, this is the joint, the Z joint or that facet joint. So it's supplied by nerves. Those nerves are called the medial branches. The medial branches allow those joints to be painful. It allows them to cause pain. Each joint is supplied by 2 nerves. So what we do in order to figure out, number 1, is the pain coming from the joint, and number 2, would you be a good candidate to get another procedure done, is we actually block the nerve with a little bit of anesthetic. So we take a needle, place it next to the medial branch, and put a very small amount of anesthetic directly around the nerve. Generally, for the low back, it's the bottom 2 joints that will cause the pain. So the L4-5 and L5-S1 facet joints. So we'll block the nerves that actually supply the joint. We measure your pain beforehand. We block the nerves. We get you off the table. We measure your pain directly after. If you have, I use 80%, 80 to 100% relief of your pain, you might be a good candidate to get this procedure done. So what we do, if you have a positive block, is place the probes. This is just an example of a medial branch block. So we're just in a groove here and blocking the nerve. You can see how small amount of contrast is injected. So if you had a positive block, a positive medial branch block, you might be a good candidate to get this procedure done. It's called a lumbar radiofrequency neurotomy. So what we're doing, we're placing the probes a little bit differently, but we're placing it directly around that medial branch. And like I said, the medial branch does not do much else other than allow those the joints to be painful. It's not a motor nerve. It's not supplying the function in your leg. So we actually create a lesion. We burn at 80 to 85 degrees for 90 seconds directly around the nerve. And this is all done with you awake. We're having a conversation. We're just numbing up your skin. The whole procedure itself per side takes about 30 minutes. Depending on how you respond with the medial branch blocks, you can expect a duration of pain relief of at least 6 months, if not longer. Most of my patients I've been seeing are about 9 months to a year, and this can be repeated as needed, and that's the key. The nerves will regenerate over a period of time. The reason why you're getting that lasting relief is because we've created this lesion. Eventually the nerves regrow and supply the joint again. But the good thing is that you just repeat the procedure as needed when the pain comes back. And it gives you the same amount of relief and for the same duration. So I'll have patients come back every year and say, I'm ready to go again. It's starting to happen again. And we look at a bunch of things when we do things like the blocks to figure out whether or not you're a good candidate. We look at your overall function. We look at how you're bending, how you're moving. So all of those things are important. Another thing I want to talk to you about a little bit, and we're changing gears entirely here, is something called spinal cord stimulation. And that's something that I do at Coordinated Health in conjunction with one of our surgeons as well. So spinal cord stimulation has been around for a long period of time, and it's really recently in the past 10 years that the technology has gotten really, really, really good. So things like spinal cord stimulation are reserved for specific types of patients. We'll talk about those indications here in a second. But what we're doing is we're actually applying electrical stimulation directly to the back of your spinal cord. For back pain and leg pain, we're applying that stimulation directly to the mid-back. For back pain and leg pain, we're applying the stimulation directly to mid-back. For neck pain, it's going to come up higher in the neck here. So the indications for spinal cord stimulation, one of the major ones is failed back surgery syndrome. If you've had back surgery, you still have pain either in the leg or arm, and further surgery hasn't been recommended, this might be a good option for you. Something called CRPS, which was previously known as RSD, it's a complex regional pain syndrome. Radiculopathy is just, like we talked about, radicular pain related to issues in the neck or back. A plexopathy is just injuries to nerves. Arachnoiditis is inflammation of the spinal cord itself. And peripheral neuropathy is another big one related to diabetes or another issue that hasn't been able to be controlled with medications. Actually, these are not FDA approved in this side, but one of the major indications in Europe is actually peripheral vascular disease. They've been using this quite a bit with success. So how do you determine whether or not a patient's a good candidate for something like spinal cord stimulation? Do you have a diagnosis that we talked about in the previous page? There are some things you have to do to get this done. You have to see a psychologist just to ensure that you're able to give us a good response. But one of the major things is determining whether or not the pain's primarily in the legs, back, or both. Generally, patients will do better with leg pain. However, some new technology that's come out has shown significant improvement in back pain. It's something called high-frequency spinal cord stimulation. So, this is simplified a little bit, but what we're doing is actually placing a lead through the lower part of your back, and we thread it up into the mid-back. And this would be for someone with back pain. What's nice about this is we're able to do a trial. So we're able to see if this would work for you without any sort of invasive surgery. So we place the lead under fluoroscopy or using the X-ray machine. And you can see it here. It's a little bit dark, but you can see that lead in the mid part of the back. And this is another view. So the lead is placed here. We'll thread it up through a needle into the mid back area. Once it's into the spot where we want it to go, we'll turn it on. And this is done in the OR with you awake. We'll turn it on and say, do you feel this little stimulation, this vibratory sensation in the areas of your pain? Once we get good coverage of where your usual pain is, we'll just secure the lead with a dressing and attach it to an external battery. And this lasts for about 5 days. During that 5-day period, we measure your pain. You're in contact with me, a device company representative. We're looking at your functional improvement. We're looking at your medication usage. And I see you back in 5 days. Regardless of how you did with the trial, the lead's going to come out. If you do well with the trial, you can consider getting a permanent implantation. It's a minimally invasive surgery. One of our surgeons here at Coordinating Health does do it. And the lead, something called a paddle lead, or you could do it through the skin again, is just sewn directly over the area of the spinal cord. It's a small incision. And they just removes a very, very small piece of bone. And then everything's internal at that point. The lead is then tunneled underneath the skin, and a battery is placed just underneath the soft tissues here in the buttock region. And you're able to control it. You're able to turn it on, off. You're able to function through different programs and cycles. So it's pretty interesting stuff. Little anecdote, I had a patient last week where we did a spinal cord stimulator trial on. And this particular patient had 2 back surgeries and still had pain. And we think it was because of some scarring around a nerve. It's nothing that the surgeon did. It's something that just happened. You develop things like fibrosis. She was on a lot of opiate medications from another physician, and we had talked about what the further treatment options could be, and we talked about spinal cord stimulation. We put the trial lead in on a Wednesday morning. I got a call from her Wednesday night saying, when can I get this put in permanently? And we tracked her throughout the whole trial period, and she actually stopped using all her medicines during the trial period, which I had to yell at her about because she was on some higher doses. You can't just come off that right away. You got to do it slowly. But she had 100% relief of her pain, and she's going to be implanted shortly. So she did very, very well. And those are the types of things that you see that when you're in this pain for a long period of time, this might be an option for you when there's not much else to be done. So just some advantages of spinal cord stimulation. It's an effective alternative for chronic pain. It's an effective alternative to getting reoperated on if that's not an option. And it's a reversible procedure. It's not really destructive. We're not changing morphology of anything, and it can be removed if needed.
What's the percentage of people that have it removed?
It's hard question to answer. It's not that common because for some reason, if say you didn't have effectiveness from the stimulator and you got it implanted, oftentimes it'll just be left in place. The lead will be left in place, the battery will be removed because it's not really causing you much of an issue there in the mid-back. But you certainly can get the lead taken out. The overall percentages, I can't give you a good answer. Okay. Yeah.
How is it going through airport security?
You'd be okay. Just a pat down. No, it wouldn't cause an issue there. There used to be some limitations with MRI compatibility. You couldn't get an MRI directly over where the lead was, but with the new technology, many companies are MRI safe and compatible completely. They might need to alter the magnet a little bit, but for the majority of companies, you can't have an MRI without an issue.
Does Dr. Wagner do any of this?
Dr. Wagner does not do spinal cord stimulation. Dr. Laguidice is the surgeon that does spinal cord stimulation.
I've had 2 surgeries with Dr. Wagner, and he suggested that I actually need one more surgery, but I'm reluctant because of my age.
So spinal cord stimulation will often use when there's not a need for another surgery, if there's not a surgical correctable lesion. So things like scarring or inflammation around the nerve or the spinal cord. So oftentimes when there's a surgically correctable issue, that might be the better choice than something like this. But each case is a little bit different. And then there's some long-term studies looking at spinal cord stimulation, And patients do well over periods of time. There's 2-year data, 4-year data, and so forth that shows that it is effective in relieving patients' pain.